Hello, everyone. Welcome back. I hope you're all doing super well. My name is Karan, and today we're going to be talking about congenital defects and malformations. So, what are neural tube defects? Well, as the name suggests, you have an issue with the neural tube itself, particularly its closure. Now, during gestation, if you remember your embryology days, you have a kind of a process where it gradually folds upon itself and closes, right? And that happens in a craniocaudal fashion. What I mean by that is you have closure at a few ends. So you have the cranial side or the head side and the caudal or the tail side embryologically. And a defect with any of that can lead to a neural tube defect. It's closely linked to folate levels during during pregnancy and preconception as well, which is why most women, or actually all women, are advised to take folate. This is usually taken at a dose of 0.5 mg per day if they do not have risk factors for a neural tube defect. However, if they do have risk factors for their offspring having a neural tube defect, then they take a higher level, which is usually 5 milligrams a day. These risk factors can include medications like anti-epileptics, steroid therapy, if they've had a child with the past neural tube defect, and so on. Neural tube defects can be detected, or there is an association with neural tube defects and a hormone called alpha-fetoprotein. And this is also commonly used for quadruple testing for Down syndrome as part of the second trimester combined screening. Going back to how it presents, so as I mentioned, it can happen at two ends. If that failure of closure is happening at the cranial end, then it can lead to the absence of a skull and a brain. That would be called anencephaly. And that leads to, this is a bit rude, but a frog-like appearance as shown in the picture here, where there's obviously an absence of most of the cerebral architecture. However, if it's the posterior caudal branch that fails to close, this would lead to spina bifida most typically. And there are a few types and there are a few complications that are worth knowing. The first one includes spina bifida occulta, and this presents as a dimple or a patch of hair over the defect. And this is quite benign and usually doesn't have any major complications. The other big one is where you have more kind of invasive issues. And the two important ones worthwhile knowing include meningocele and meningomyocele. Now, if there's also cystic protrusion of the actual CNS tissue, then this is what they are. A meningocele purely means that the protrusion is of the meninges versus a meningomyocele, where you have the meninges plus some of the actual spinal cord protruding out as well. Obviously, there are surgeries to do that can correct them, but I guess you can tell that which one of these two is going to present more severely. Next, we have cerebral aqueduct stenosis. So talking a bit about how CSF is produced, you have your two lateral ventricles, then the third ventricle, and the fourth ventricle. You also have the cerebral aqueduct and ducts of Luschka. Anatomically, I don't know how relevant that is. There's the aqueduct of Sylvia and the duct of Luschka. But if you have a blockage, that is going to lead to a hydrocephalus. Now, this blockage can be because of a few reasons. You can have actual structural defects, you can have compressive reasons, but from your level, what you need to know is that if we can't drain the CSF out successfully through the entire CSF column, that is going to lead to the accumulation of fluid in the lateral ventricles. So you're going to have a whole bunch of fluid in the lateral ventricles that's going to balloon up, and you're going to end up with a big head. Now, this is interesting because when this happens in children and newborns especially, they present with an enlarging head circumference because the ventricles are dilating. But then when we talk about hydrocephalus in normal populations, it usually doesn't present with dilating head circumferences, and the head circumference still stays relatively the same. Well, why does this happen? Well, it's primarily because the actual anatomy of the skull of newborns is very different to that of adults, and the suture lines aren't well formed at this point, which is why there's a lot of room for the skull to actually expand and dilate if there's increased pressure. And you don't actually have as big of an increase in the ICP with these cases because the skull can dilate and accommodate for this, versus an adult skull, which is going to be very rigid, where although you may have increasing fluid in the lateral ventricles, that would increase the ICP, but wouldn't cause dilation itself. You can treat that with a ventriculostomy or a ventricular peritoneal shunt, where what we're basically doing is we're inserting a tube between the ventricle and the peritoneum. Now, the peritoneum is a super good space in the abdomen. So it's a good space because it can absorb this fluid relatively easily, so they don't have to excrete it somehow, it doesn't have to be excreted outside the body, what I'm trying to say. So that's relatively effective. The last topic is syringomyelia. Now, syringomyelia is not a congenital issue, but it is mostly, it is a cystic degeneration of the spinal cord, most commonly after a traumatic event. Most cases on exams and most questions typically refer to some kind of sudden sporting injury or a motor vehicle accident. And this typically happens in the C8 to T1 or the cervicothoracic region. As you can imagine, as the cystic structure is expanding, it's going to start compressing on the spinal cord and the various tracts running within the spinal cord. And it typically affects pain and temperature because it's affecting the spinothalamic pathway first and doesn't really affect the fine touch and vibration sensations because it relatively spares the dorsal column medial lemniscus pathway. Now, because it is a cystic expanding structure, at first it's going to start with compressing the structures nearest to it circumferentially, and then it's going to expand outwards, which is why it presents with what's called a cape-like distribution. So usually it presents with kind of involvement in the upper limbs first, gradually going down the arm, and that can eventually progress onto the lower limbs. And that's all we had for our congenital and congenital malformations and neural tube defects and so forth. I hope that helped. If you have any questions, again, get in touch. And as always, please look after yourself and please look after your loved ones.